ventilation. Oh, all right, I need some help to get back on show. Where's my, yeah, I don't know what how could I do that with this? You don't know. You need to go, show is usually down here. Do I see it? It's the, yeah, it's that one, thanks. Well, I've done things, but I've never done it with the clicker. All right, so women, men can be a diagnostic challenge, women can be a diagnostic. Now, chest pain units, I asked to talk about that. So the chest pain unit is where patients are triaged when they come in with chest pain. If the EKG is normal, the first marker, the first troponin is normal, they're clinically stable, but they have suspicious pain minutes before or an hour before, and they come in, and they're looking okay. And particularly, the first troponin is negative. They are then triaged back to the chest pain unit and are termed low risk for an acute coronary syndrome, for a myocardial infarction. 3%, less than 3% probability if all of this is present. Atypical chest pain is stable, the EKG is normal, and 1 or 2 troponins are normal. But low risk is not no risk. That's why we have chest pain units. I told you this was a protein released from injured muscle into the blood. There are scores that should help the clinician in taking the history and the physical. I'm not going to show you all of them, but this is called the heart score for chest pain. It was originated in Europe for patients with chest pain in the ED. You get points for if the history is highly suspicious all the way down to slightly non-suspicious. If the EKG shows ST abnormality or is normal. Age goes up, you get more points over here. If you have a lot of risk factors, like high cholesterol, hypertension, smoking, if the troponin is up or is normal or very, very low. So then we take the score. We don't use these. We use our clinical judgment, and when we do it, it encompasses actually all of this. I'll show you something else. There are so many tests to do with the stable patient who comes in and is in the chest pain unit that we reviewed them in 2010. A group of us across the country reviewed them and evaluated these tests, from the treadmill to nuclear study to exercise echo that Bill brought to UC Davis. And each institution has its favorite, the one it's accustomed to, the one it's trained in, and uses it, and they're all excellent. CTA, computed tomography, coronary angiography is in there, coronary calcium is in there, but the patient is now he has been triaged into our chest pain unit. He doesn't have a heart attack at this point, but still suspicious. He comes from the emergency department, he's stable, everything else is fine, but the history, recent history is not good. He is considered low risk and goes to the chest pain unit. In the chest pain unit, the decision is made, more EKGs, say every 15 or 20 minutes, more troponins. If negative, then a confirmatory test might be done. And those are the ones I just mentioned. That could be a treadmill. It could be all the way from a treadmill all the way to computed tomography, coronary angiography, the test that you heard. We've never done that in the chest pain unit in, I guess, 15,000 patients since 1994 in the chest pain unit. We've never done CTA in a patient in the chest pain unit. If we do treadmill or we do an exercise echo and a nuclear is negative, the patient is discharged for follow-up to see what this was due to. If it's positive, abnormal, the patient is admitted for the workup right now. And now we're saying, is this confirmatory test always necessary? Because these confirmatory tests are very good. They approach 100% reliability. The echo is there now too. There weren't, at the time I wrote this, there weren't enough echo papers done. They're up there at 99%. CTA, also greater than 99%. MRI, there are so few of those done. I put it in small font, and I didn't even put the data. There isn't enough data. No additional test. If I just said on the previous slide, do you really need to do these confirmatory tests? We have been doing fewer and fewer. No additional tests. Now 40% of our patients that come to the ER with chest pain and are considered low risk are discharged. That might be a younger person, very atypical symptoms, but still we want to cover ourselves, and so they are admitted to the chest pain unit and they're discharged. But the chest pain unit spread goes from the 30s all the way into the 80s. The negative predictive value of these patients, 1,000 patients, 1,038 patients, over several years we've discharged, we have had one event within 30 days. The negative predictive value is 99.99%. That means if the tests and our evaluation is negative, it's virtually 100% correct for 30 days. 30 days is the standard, means that if there's an event within 30 days, we missed it, because an MI may take time to blossom. But if it happens outside of the 30 days, then that patient should have been worked up when we're sent home to see what might have been causing this. Could have been a treadmill, could have been a cath, could have been a lot of things. Didn't need it at that time. So our job and the job of chest pain units around the world is accuracy, rapidity, because these patients can really congest, and cost-effective in terms of resource utilization. Accuracy is the most important. So we've done very well, and all chest pain units all over the world have done very well and strive to get these kinds of results. But the 30-day issue is universally, Europe, Asia, America, South America, North America, it is accepted as you are accurate if there is no event within 30 days, no cardiac event. Now, I was asked to say something about, I need a little help again. There's something on here that I did that takes me off of show, which is down here, right here. The cursor right there. Right there. No. You see this thing right here? Right there, that lamp? Right there. Yes. Yeah. Perfect. Okay. And I was asked to, okay, so CTA, you've heard about computed tomography coronary angiography, which is a miraculous technique. Many of us didn't think we would be alive back in the 90s, that we would be alive when CTA, a non-invasive, accurate technique to define the coronary arteries, would be invented. We knew it was coming. There was work on it. But it developed like all other technology so fast. It's very accurate now. It approaches the diagnostic capability of the standard invasive coronary angiography. So here's what the coronaries will look like. This is all cleaned up, and what you get is a picture of just the coronaries. And here's the right coronary. You see, this is diseased. It looks like there's some disease up here, a lot of disease in the left main coronary artery here. And the technique is amazing. It'll turn. Have you seen the CTAs?
I haven't, but I think there's a place in Redwood City that is doing this.
Well, they're all over.
Yeah.
Everybody has them now. They're $1 million machine. So you turn. They can turn. Look underneath, on top, in back. It's unbelievable. So they're very, very good. I don't want it, in my own view, to be the Midas touch. It's fantastic. I have a slide with the Midas touch. Is it gold or is it the Midas touch? So these are the updated NICE guidelines, the National Institute for Care Excellence is the acronym it comes from, but it also comes from other things. But they're all the UK, England, the NICE or the NICE guidelines. Cardiac CT as the first-line test for coronary artery disease when the patient has chest pain. I have a real problem with that, I have to tell you. Now this thing's stop. Okay, here it is. The summary of this article. which was in Current Cardiovascular Imaging Reports, 2017 paper. NICE recommends, a plural, excellences, recommend cardiac CT as the first-line test for the evaluation of stable coronary artery disease in chest pain pathways. So that means if you get chest pain hurrying here, and I got a little chest pain, I better go to the doctor and he better do a cardiac CT. I think they really went too far in this. That's my view. This is a very controversial area. It's incredible technique, and it should be done, and I may be not doing justice to this article because they say stable coronary artery disease, and then a patient has, let's say, impressive angina and a lot of risk factors. Okay, well, that's the kind of patient we would send to the cath lab, because that patient is going to have lesions pretty well if we are astute clinicians, and they're going to be fixed. But this means a cath, they get dye, not good for the kidneys, radiation, young women, chest being radiated, and then if there are lesions, they have to go to the cath lab. So the whole thing is done again. So it's got to be highly selective, highly selective. It shouldn't be willy-nilly. You've got chest pain, doctor, I want computer tomography. Calcium, coronary calcium is another story. That did not make the cut a few years ago for tests in chest pain pathways, and now it's up as a recognized approach. And if you have zero calcium, zero coronary calcium, you can be virtually certain you don't have obstructive coronary disease. But even a little score, it might not be calcified yet, and there may be that lesion that I showed that's less than halfway occluding the coronary and not calcium in it yet. Takes time. And from those lesions in the patient without angina, because blood flow can go up with a 50% narrowing. It's simple plumbing. It's in our pipes in our house. It's in our coronary, renal arteries. It's everywhere. 50% does not reduce the flow reserve when you're running and you need more flow. Certainly for the activities that men and women, not us, who lead lives of quiet desperation. Certainly not, okay? So this is interesting. Now, this is not talking about people who come to the chest pain unit. There is a very strong advocacy of doing this test also in the chest pain unit when people come in first thing. That should be the screening test. And I've engaged in debates with good people at the American College of Cardiology and at the Society for Cardiac Patient Care, and there are people who do this. So it's a controversial area. We have so many tests, a lot of issues about which is the best test. Now I want to show you something. This is, in fairness, 2012. It's a few years ago. This is what can happen. Nothing good in our profession comes without limitations, and we have to be aware. So revascularization after CTA for low-risk ED, patients come to the ED, chest pain. Low risk, the kind I've been talking about. They got CTA instead of the algorithm I showed you. These are 4 different studies, and these are very good studies. They're randomized, controlled, prospective. Very good in terms of science. These are the patients who got usual care, which is a disaster in this country. It's slow, it's inefficient, it's inaccurate. The patients stay in for a day and a half. It should be hours. It should be either, the decision should be made in hours. Either you can be discharged or you need to be admitted. So usual care, this is at 1 year. At 1 year, this is revascularization. They got angioplasty, stent, or bypass surgery. Of the usual care, only 1%. Of the CTA, 5%. So CTA found lesions. They went to the cath lab, five times as many. CT stat, this one anyway, 2.4% usual care, 3.6% if they got CTA, because they're not seeing the lesions. These guys are. And the same thing in the bottom ones. However, okay, I need my helper to, I need a high seat for you there.
That's Katie Weber, and she is just finishing her master's degree at the UC Berkeley School of Public
She's
Health.
fantastic. That's it. One back. I'll go one back. Now, I should have, so damn fast. At the end of 1 year, there was no difference in outcomes in the two above groups. So something is happening here. It's a warning. We don't just rush to do CTA in everybody that comes in, because this is what's going to happen. Lesions that are lesions get they are attended to with stenting. It's natural. People who do stenting believe in stenting, and our group, and Bill, were you involved in the review of that our guys were doing for patients? Yeah, your man has those data, some of the data. Yeah, the unnecessary stenting, it's a concern. Now, what are the limitations of this? This is 1 year. What about 5 years, or 2 years, or 3 years? The stent doesn't have a warranty that it's going to save the person forever. So that's the other side of it. Coronary calcium is very good. The negative predictive value is fantastic. If you don't have coronary calcium, or it's very low, it's very, very good. But my view is to do the American College of Cardiology, American Heart Association, arteriosclerotic cardiovascular disease risk analysis on your phone. 5 factors, and you can get your 10-year risk. And if it's very high, then we can go to the doc, or you go to the doc, and he will decide which way you go. It might be CTA. It might be a treadmill. These guys also say treadmill should not be done in stable coronary patients, the workup in stable coronary patients. That's because they don't know how to use the treadmill. There are a lot of false negatives in the treadmill. But that's if they only look at the EKG. There's so much other information you can get from the treadmill. So I have a lot of problems with this, but it is, not this, the one before, where I said the guy showed that the first test should be CTA, and they also really knocked the treadmill. Treadmill has gotten, particularly people who have come out of training recently, everything is imaging. You've got to see it. Treadmill is not a good predictor. It's a very good predictor if you know how to use it. So there are ways to approach. You can do preventive. You can calculate your risk with calcium score, or just on your phone. We want a low risk, and even there, the risk, it says, you are at risk. You should have a high dose statin or a medium dose statin, hypertension to be treated, et cetera, et cetera. Or you can go, you and your doctor, shared decision making, can go down the CTA route. I'm showing this because it's the NICE guideline, and I want to show you. Now, no apologies for a busy slide. I know you can't read it, but there is something on here I want you to see. I had an animated arrow. There it is. This dot, this is the patient who's low risk. This box is low risk. This is STEMI, bad, different pathways. But this is low risk. And the last bullet, there is no role for routine, non-invasive imaging or exercise ECG in the initial assessment of acute cardiac chest pain. Now, if a man has an abnormal electrocardiogram or unrelenting pain, you don't put him on the treadmill. Of course not. It's going to be, how is this interpreted? Not only the treadmill, but exercise echo and nuclear, which are very informative. So this concerns me. That's what it is, and they have very good results, so they'll do what has been wonderful for them. So finally, the chest pain unit, we're about 15,000 patients. We take everybody. Everybody is a candidate. It doesn't matter whether you're male, female, old, young, et cetera, et cetera. We follow the guidelines of the American Heart Association and the American College of Cardiology. The treadmill, if the patient needs a test, our first test is a treadmill. We have never done CTA. The first test is always a treadmill. We sometimes do, many times do nuclear or echo because 1/3 of our patients can't exercise. They need a different test. The negative predictive value of these non-invasive tests for an event, not for picking up coronary disease, for an event right now or at 30 days is 100%, virtually 100%, 99.7. Then the patient has to not be forgotten. Has to be for anybody who goes to the emergency department for chest pain. That's an important event, and that has to be followed through on. Other centers, nuclear stress, stress echo, CT angio, UCD, the length of stay. This is the thing about CTA. One of the big things that they boast about, and it's very good, is it's short, it's brief, it's efficient, and it's not expensive, which is really interesting. Stress echo is more expensive than CTA. Length of stay in our unit can be as short as 4 hours and up to 12 hours. That is very short, and it beats the national average, which goes up to over a day, and it's shorter than CTA, which really boasts about its short time. So I was asked to write an editorial in a very good journal, not JAMA, JAMA Internal Medicine, and I termed this the patient with chest pain, low risk, high stakes. And out of this comes, in the current state of our knowledge, it is reasonable to call for a halt to routine cardiac testing in favor of physician discretion selection of patients for pre-discharge testing from the chest pain unit. This isn't talking about the guy who comes in with crushing chest pain. This is the guy who's worked up and done well. And even in, I think in that guideline that I just showed you, there's a space for reassurance. That's the intervention, reassurance, not an additional test. So quickly go through the guidelines. These are the 2014 guidelines, and patients with a heart attack with the EKG shows that drop, the drop, not the elevation in the ST, but the drop. So I'm just going to show you some, we're going to just review again. We have normal ST segment, ST elevation, that's the same thing here, and then drop below that dotted line. So these are the big heart attacks. These are the heart attacks that are very important. They're not small. They can be big also. It's different. And that's our guideline. And then taking you through this, the plaque, the rupture of the plaque, and then, again, the type of occlusion, ST elevation or not. So guidelines are continually reassessed. And the one we did here was the last one for the ST depression, the non-ST elevation. And right now, we just began a guideline just on chest pain. There was none before. There were heart attack guidelines, there were angina guidelines, but there wasn't a chest pain guideline. We're just in the first weeks of a new ACC/AHA chest pain guideline. So constantly reviewed as the evidence comes in, the recommendations change. Recommendations, here's how recommendations go. This guideline was 100 pages with 1,000 references. It took 2 years. It's picked by experts. The experts at the American Heart and American College of Cardiology, up at the epitome of administration and expertise and experience, pick co-chairs or chairs for the guideline, and then they work together and pick a group of about 15 or 20 people who will work on it and write the guidelines. And it has to be at least 51% have to have no involvement with industry, cannot be doing trials, drug trials. Now, since a lot of very good people are doing that, they can come on as reviewers. And then as you move along in the guideline, you kind of don't know who's the person with RWI, tainted, relations with industry. They've had relations, but they're with industry. And the others are those of us who are not doing anything with the drug companies or with the device companies. So here's an example of timing of urgent bypass surgery in patients who are on antiplatelet agents, blood thinners. They're going to open the chest and they're on blood thinners. So we say non-enteric aspirin should be used. It's a 1. Class of recommendation. 1 is the best. It means should be done, is good. A B means the trials, there aren't the biggest trials, but there are lots of small trials supporting it. And then if an elective bypass surgery and one has been on Plavix or the other blood thinners, wait 5 days, 7 days for this particular drug because you're opening the chest and bleeding. Still a 1 with B recommendation. And here's a little hubris. A C means we have no evidence, but we're pretty smart, and it's our recommendation. We try to keep the C recommendations down, level of where there's no evidence. Urgent bypass surgery, DC, discontinue these blood thinners at least 24 hours to reduce major bleeding. That's a 1 with a pretty solid level of evidence. That's how it goes. And we argue and we debate, and this is about beta blockers in a patient with a heart attack. They should be given in the first 24 hours unless there are contraindications. That's a 1A. Big monster trials, thousands of patients. And then stabilized, but they have some heart failure. 1, you can give it, but be careful, that's consensus. We don't have good data. Intravenous, don't do it. It could be harmful. That's a 3 with fairly solid evidence. And then we debated initial invasive strategy. That means the patient comes in, goes to the cath lab, even with ST depression, like the ST elevation. And there is an ischemia-guided strategy. If we have objective evidence that the heart is not getting enough blood, there's ongoing chest pain, that's another way one can go. So 2 ways, and they complement each other, actually. So here's what we can do, the interventionist can do. The patient comes in, he's got evidence of a heart attack. It's a very important artery, the left anterior descending artery. And there's a tight lesion, pre-angioplasty stent, the balloon, the catheter is put in, the balloon is dilated, the stenosis is reduced to less than 30% from about 85%, and then a stent goes in there. And our guys are very expert at it. And here's what it looks like afterward. You can still see a little bit there, but it's excellent. So that's the miracle. Bypass surgery. All right, I need some help here again. I wonder if I have show on. Yeah, I have show. I have show. I've never had a pointer that had show, but now I have to race. We're going to race. Yeah, because we're at the last slide. We're at the last slide. Okay, we're very close to the end, everybody. Yeah, I love that arrow. Animated arrow, great. This one, and let's get to the bypass. Yeah, here we go. And now, picture of bypass surgery. So I've never had it. There's a show thing right here that you can do, and I've accidentally been hitting it. So bypass surgery, the veins are taken from the leg. There's probably somebody's been here today that may have had bypass surgery, and somebody with a stent, except we're all very young here today, maybe not. So here's the aorta. The big artery comes out of the heart. Here is the diseased artery, and here is the vein that's anastomosed into the aorta, and then goes down beyond the detours around the tight narrow ones. So that's bypass with the vein. This is the internal mammary artery graft, or internal thoracic artery. This artery is taken from, it's an artery that feeds the middle part of the rib muscles, and we can spare it. So it's detached from the rib muscles area. It's still attached to this artery, and then it's brought down and put in to the anterior descending, the one on the left, which is really the one we use. This is unusual. Goes down around behind to the circumflex. Artery into artery is better than vein into vein, but vein into artery with an artery with a 90% stenosis is damn good. So finally, this is it, finally. You can relax now. So performance matters. We have a lot of therapies that we give to prevent the next heart attack. The biggest risk for a heart attack is one has had a heart attack. So aspirin, I'll probably run out. Aspirin, beta blockers, ACE inhibitors or angiotensin receptor blockers, cardiac rehab, diet. If the person, it's been shown that people